April 2015. This man, 60-year-old, presents to his primary care physicians with complaints of some fatigue, some weight loss, primarily though changes in the bowel movements and some blood in the stools. A workup follows, including a colonoscopy, which shows a mass on the right side of the colon, which was biopsied, then shows evidence of adenocarcinoma consistent with a colonic primary. The patient was staged. There was no evidence of any other disease. So he was sent to the surgeon at that time, underwent a laparoscopic right hemicolectomy, and he was staged at 3A. So that's low risk colon cancer with essentially a decision that followed to proceed with adjuvant chemotherapy. And based on the IDEA trial, the decision was to proceed with 3 months of capecitabine plus oxaliplatin, followed by close observation as per routine. The patient did fine with the capecitabine and oxaliplatin with Capox, with grade 1 neuropathy, relatively tolerable, very little hand and foot syndrome, but no major toxicities. 30 months later, so that's April 2018, the patient started having some symptoms of abdominal pain, again some fatigue, some weight loss. Over 2-3 months he lost about 10 pounds or so. The patient was overall not feeling well, so there was a concern that this could essentially be an element of progressive disease. He was scanned at this time. PET-CT shows evidence of both liver and lung metastases. To confirm the diagnosis, since about 30 months elapsed from the end of his adjuvant chemotherapy, a decision was to biopsy one of those liver lesions. Indeed, a biopsy suggested an adenocarcinoma, which was consistent with colon cancer. His CA was on the rise at that time. Additional genomic sequencing suggests microsatellite stable tumor, RAS wild type and BRAF wild type. So molecular testing was performed, showing evidence of RAS wild type, BRAF wild type, microsatellite stable, and HER2 non-amplified. The patient's ECOG performer status was 1, maybe a little bit less than 1. I'm still relatively active, doing things, moving around. Patient is relatively symptomatic of right-sided tumor. So the decision at that time was to start the patient on FOLFOXIRI plus bevacizumab, given the symptoms, given relatively younger individual at now 62, 63. And then the goal was to expose the patient to about 2 to 3 months of FOLFOXIRI bevacizumab and then transition to maintenance therapy. The patient proceeded with 6 cycles of FOLFOXIRI bevacizumab, almost complete resolution of the symptoms, getting closer to a grade 2 neuropathy. I think some of the cumulative neuropathy from oxaliplatin and with the FOLFOXIRI. A PET-CT at that time showed near complete resolution of his lung and liver metastases, with a great dip in his CEA. At that time, we dropped oxaliplatin, continued with FOLFIRI for another 6 cycles, checked scans. Scans continue to look great. At that time, some fatigue, some elements of toxicity related to the chemotherapy, diarrhea, and others, led to stopping the irinotecan and the 5-FU, continue the avastin, moving this to every 3 weeks, and then the patient was switched to oral maintenance chemotherapy with capecitabine. So capecitabine, bevacizumab every 3 weeks, capecitabine daily, 5 days a week, Monday to Friday, and then weekends off. The patient did extremely well with the treatment for about 2 cycles, and then started developing symptoms again, fatigue, abdominal pain. His neuropathy was still grade 1 at this point, when it actually went down from grade 2 to grade 1, but it was a grade 1 bordering on grade 2. And then the decision at that time was that this is a patient that remained with significant neuropathy, progressed within 2 months of stopping FOLFIRI, on maintenance therapy, so it was time to switch to new therapy. Now, this is a right-sided tumor, so we understand that the options are relatively limited. Decision at that time, after discussions with the patient, was to proceed with regorafenib, starting with a dose of 80 milligrams orally every day for the first week, with the goal to dose escalate 40 milligrams per week orally until we reach 160 milligrams within 3 weeks, if there are no significant toxicities related to the regorafenib.